Good morning. So today's topic is on osteoarthritis, and I'll just be giving a brief outline of it. Osteoarthritis, what it is a chronic and progressive condition that mostly affects the hands, spine, and joints such as the hips, knees, and ankles. It's the most common form of arthritis and the predominant condition leading to knee and hip replacement surgery in Australia. So a bit of epidemiology. Osteoarthritis is the most common form of arthritis in Australia, comprising around 62% of all arthritic conditions, and it affects around 1 in 11 Australians, which is approximately 2.2 million people. Patients with osteoarthritis are twice as likely to describe their health as poor, and most common cause of chronic disability in adults. And from 2017, 2018, so from 2005 to around 2018, we've seen a 38% rise in the rate of total knee replacement surgeries for osteoarthritis. So what causes it? A bit of pathophysiology. So it's initially believed that it's all down to wear and tear, but more recent research shows that the pathogenesis involves a variety of factors, including inflammatory processes, as well as the biomechanical factors. So we have got chronic stress and strain on the joint and age-related reduction in proteoglycans. Proteoglycans are a key component that makes up your joint cartilage, and what that results in is in all these chondrocytes proliferating and becoming pro-inflammatory, and that results in an abnormal matrix with the release of all the inflammatory mediators, leading to eventual apoptosis, and that further leads to loss of elasticity in the cartilage, which becomes quite friable, and the matrix of the joint degenerates, and that's how you can see some loss of joint space on X-ray. You also get vascular invasion into the joint, and that leads to formation of osteophytes and some subchondral sclerosis as well. Risk factors for osteoarthritis can be classified into modifiable and non-modifiable ones. So the modifiable ones are your obesity, muscle weakness, trauma, sport, particularly the ones that involve high impact or repetitive use of the joint, occupation as well, especially if it involves a lot of heavy lifting. Non-modifiable ones are age, female gender, and family history. Clinical features, most common ones upon history would be exertional pain relieved upon rest, joint stiffness and reduced range of motion, some swelling. Typically you might see asymmetrical joint involvement, perhaps some crepitus on joint movement on examination, and if it's very severe, you can have morning stiffness lasting less than 30 minutes. Typical findings on the hands include Haberdin and Bouchard nodes, and commonly affects joints such as hands, spines, knees, hips. How it's diagnosed: it is basically a clinical diagnosis, and you would consider this diagnosis in a patient more than 45-year-old with clinical features. ETG says that radiological findings of osteoarthritis are poorly correlated with osteoarthritis symptoms. So usually you would use radiographic imaging, mainly to support the diagnosis instead of diagnosing it. So imaging, 4 key radiological signs of osteoarthritis include loss in your joint space, as you can see in the X-ray, some osteophyte growth around the edges, subchondral sclerosis, and subchondral cysts. terms of management, you can have non-pharmacological management or pharmacological management, as well as surgical management, which I will touch on in a bit. But the main thing is to individualize goals of management to the patient and have patient education, especially in any chronic disease that the patient would have to live with. So non-pharmacological management is exercise. So one of the risk factors was muscle weakness. So you want to strengthen those muscles. Another option is to lose some weight. Some recent study has showed 50% improvement in symptoms with 10% weight loss. Mobility aids as required. It essentially reduces pain and improve function, and some psychological support as well. Just because it's a chronic disease. Alright, and in terms of pharmacological management, you can use topical NSAIDs or capsaicin for pain relief, as well as oral paracetamol or NSAID. Another option is to use intra-articular corticosteroid injections. Can be rapid onset for occasions, going to events such as weddings, or just simply to allow the patients to participate in strengthening exercises on a regular basis. Duloxetine is another option. It's an SNRI, and it's used often if there's persistent functional impairment despite adequate strategies, especially the first three. If that's not successful, you might resort to duloxetine. Opiates have a limited role here. It's only for short-term use while the patients are awaiting surgery. Surgical management is advised, and if the patient experiences ongoing severe functional impairment or pain despite maximal conservative management. So two options. One is osteotomy, another one is joint replacement. Osteotomy basically involves cutting the bone to improve the knee alignment and relieve some of that pain by reducing intraosseous pressure. It's less commonly performed just because of how successful joint replacement surgery is. And joint replacement surgery is very common. It can be total or partial replacement of the joint using an endoprosthesis. Some of the indications and contraindications, as mentioned previously, joint replacement is indicated for severe pain refractory to non-operative or conservative management. Contraindications to a total knee replacement surgery would include things like active infection, chronic lower limb ischemia, skeletal immaturity. And contraindications to your hip replacement surgery might include things like active infection, pre-existing significant medical problems, skeletal immaturity, quadriplegia, permanent or irreversible, muscle weakness in the absence of pain. And that's brought us to the end of our presentation. That's all my references.